Hello and welcome to Filibusters in Fine Print, where AMGA's public policy team gives you the insider view on healthcare regulations and legislation. Thanks so much for joining us for the latest from Washington, D.C.
Good morning and welcome to Filibusters in Fine Print, AMGA's public policy podcast with all the healthcare policy news that's fit to print. That's again a copyright violation. I am your host, Chet Speed, and we are here with our public policy experts. Why don't we introduce ourselves, and then we'll get to the topic of the day, which is a letter to HHS, which outlines all of our priorities for the next, 10 to 20 months. Is that right?
It's going to keep me very busy. All of us very busy.
It is.
I'm excited about it.
Dale's very excited because this policy is all about him. However, Daryl.
Yes.
You are second string today because Lauren brought us a cake celebrating our 50th episode
It was.
of this podcast. Yeah. So she might just take this over.
I can't compete with cake, so Lauren, you go ahead.
Yeah, it's a nice cake. You can put like a file on there to escape from prison. Yeah.
This is called a power move, everyone.
It's DC.
It's DC.
I noticed it's only one tier, so, you know.
It is 2 tiers. Do not, no.
Oh, no.
We're not doing that, sir.
It's like frosting, like
I
real
thought you had to
frosting
put like
flowers.
columns to make it a tier. Is that not how what a tier is?
That's a lot of frosting.
It's more tiers than you got.
Yeah, no.
All right, why don't you introduce yourself? And in shame,
hi.
I should add.
Yeah, hi everyone. Daryl Drevna, Senior Director of Regulatory Affairs, and looks like I'm going to bring like donut holes in next week or something.
Oh, I said the snack
That's good.
challenge.
That's good.
Yeah.
Okay. All right. Gene, what are you bringing?
Chick-fil-A. Jamie Miller, Ambassador Goodwill here at AMGA.
Alicia Sawyer, GR Assistant.
Lauren Latney, Cake Queen, also Director of Government Relations here on AMGA.
Is that a TV show, Cake Queen, or is that Cake Boss?
Cake Boss.
Cake Boss. Yes.
Yes.
I'd
It's that
rather
guy
see.
from like New Jersey.
Good buddy.
I'd rather see
Yeah.
Cake Queen. That sounds even more fun.
All right. Well, Lauren, thank you.
Well, we're all together.
Yeah, glad. Yeah, we all are together.
We are all together. You guys were on field trips last time we
Right.
met.
Yes, we
Oh,
were.
we were. Yeah.
Yeah, where
Yeah,
were we?
Seattle and board meetings.
Oh, right. How'd it go?
Well, we talked about you all in the last episode.
So you didn't listen?
listen.
You didn't listen, is what I'm hearing. I hosted a podcast. You came into one.
I did.
Yes.
I interrupted because it was either talking to you or the board, and I opted to be here.
Maybe we delete
love
that
the board.
later.
So Alicia, what was it like to host? Because the pressure is immense, and yet it takes extensive talent to be able to host a podcast. It really does. So what'd you think?
Well, I got an email from Harry this morning saying that I did an excellent job, maybe top-notch, best episode.
Wow.
Ever.
I never got anything from Harry.
What can I say?
Yeah, what can I say?
I'm just really good naturally, like.
Humble. I like it.
Oh,
Well,
Chet has
you-
a little low mic, so it just makes
Yeah.
you over the mic.
It makes you look a little
We gave Chet
sad.
the junior mic today.
I'm
Back aches for him.
my chin is literally on the table right now, because I got here last, so I got the worst one. The other four are very happy. I'm not even sure I'll get cake today. Okay, all right, Daryl. So we sent a letter to Secretary Kennedy outlining our regulatory priorities for the next, year and a half. We talked about eliminating administrative waste, which I think is a great term, fixing doc payment, making technology work, and this also coincided with Value Week on Capitol Hill. So this was the timing was great, and the topics are great. So let's, and this is a word that Lauren taught me, let's unpack this.
Oh, that's a good word.
Yeah, it's a corporate word. Right?
Yeah.
Let's unpack the letter and tell the members what we're doing for them. So let's first talk about prior auth, which is probably one of their biggest pain points.
I think so. We hear a lot about that from our member, and what was really interesting, so in our letter we highlighted prior auth, and in one of the conferences that Jamie and I attended this week, Dr. Osler led with prior auth in his remarks. Now what was interesting, his framing was notable because he's like, hey everybody, I had a great meeting with the payer community and we talked about prior auth, and I'm hearing that providers just aren't sharing data. That's
And a
why.
pin just dropped in the room. We're
Yeah.
looking around, we're like, interesting.
Yeah, that's new to us.
Yeah, I was like, huh, how about that? So that's sort of the environment that we're, facing right now with prior auth. So, but we've got a different take on this. And I think essentially at, big picture, prior auth is broken.
We're hearing from our physician executives that they're spending 2 full days a week directly taken from taking care of patients, refuting prior authorization requests. And this is due to an inconsistent criteria, opaque decisions, and no real accountability in the system. And so we heard from one of our physician executives at AMGA, and they shared a story with us that 5 health system administrators were required for one prior authorization request.
Yeah, that was remarkable. So, and to add a little bit, right, there was a physician executive, a physician who made the original request to the physician executive, 5 administrators that we identified, it could be more, to handle 1 PA denial. When we think about it, Medicare Advantage has 53 million PA requests per year. That was in 24.
Right.
Then you add commercial, let's say probably over 100 million easy a year. And it took 7 people that we identified in this one health system to go over a PA denial.
And we're going to wonder why things cost what they do.
Exactly.
Right? But we've got some solutions to this. I think, if you cut to the chase on prior auth, we really need to expedite the decision-making process here. CMS has rolled out some timelines. We think they're too long. In our letter to HHS, hey, let's make a decision here within 48 hours. And if it's an urgent request, and that's if, someone needs to change location or get discharged to post-acute care, that really needs to be done in 24 hours. And I think let's put that in statute. I appreciate that the payers got together and have sort of a voluntary pledge. I think we're past the point of voluntary. We need to really expedite these requests, streamline them if possible, use gold carding if possible, and really eliminate to the extent possible these prior auth requests. What was it? 300 million you just said, Chet? That's just...
53 million in Medicare Advantage alone in 2024.
Yeah.
That's not including commercial.
Exactly. So there's just
gosh.
too much flowing through the system. So we need to expedite this and eliminate it where at all possible.
All right. So that's a big part of the letter, I'm sure.
Yes.
That's great. And the letter will be available on our website. So
correct.
Can read it. Yeah. Fantastic. Yeah, with Joe's picture. Okay. So
Bow tie.
What's
Bow
that?
tie?
Huh?
Is your bow tie? Are you wearing a bow tie in the picture?
No. No.
But
I could.
you're a regulatory.
He pulls it off really well.
Yeah.
I mean, he likes it.
Good.
Yeah.
All right. I believe information blocking is also part of this letter, and it's an important issue for AMGA members too.
Yeah, one of the things that we heard back from our members and something that I've been really passionate about as well is the 21st Century Cure Act gave patients the right to immediate access to their health records. This is well intentioned. When this was originally drafted, it was really focused on putting as much transparency in the system and people owning their data as much as possible. But the problem is, it's a real clinical problem in terms of sometimes you're getting information without talking to your doctor first. You're receiving some devastating news. It could be a cancer diagnosis, miscarriage confirmation, HIV results through these sort of automated portal notifications. So you're sitting in a Starbucks and all of a sudden you get a portal notification saying that something could be altering your life. And this is before physicians can provide any context or counseling on that, which is a real issue and concern.
Yeah, and we've been working this issue for a while. So, current regulations will allow a clinician or physician to put a hold on the release of those results, but only if there's a threat of physical harm or physical danger. Either that patient is a threat to themselves or someone else in a physical sense. So emotional, psychological harm just doesn't qualify. So we've had some positive meetings with the folks over ONC, or I guess the APST, Assistant Secretary something technology. I can never get that. That's the one I just
staff right there.
Just can't get that.
It's Assistant Secretary of Technology Policy or Technology and Policy.
TP.
Yeah.
Okay, got it.
Yeah.
Awesome, thank you. Actually, I heard a rumor this week that they want to go back to ONC. Yeah.
Oh, I bet. Yeah.
It's just easier because everyone's tripping over AS.
TP. It's not natural.
It's not natural. There's So go back to ONC, and put in an expanded definition of preventing harm that will allow up to 72 hours of a clinician who, in a good faith belief, thinks that the immediate release of a test result or some sort of data could result in serious emotional harm, and build plain language explanations and follow-up tools into these EHR platforms, so clinicians and patients can work together and make sure that these life-changing results are delivered in the most compassionate way possible. And I will add, we've had some positive meetings with Dr. Keene and the folks over at that office on this. So, we include it in our letter, but I'm optimistic and hopeful that they've definitely heard our concerns. Now we just need to get them to act on them.
And that's a great issue, I think. Especially a great patient-facing issue.
Yeah. I think everyone can understand this one.
Mm-hmm. Yep, and fantastic. Okay, let's talk about telehealth.
Happy to.
Oh, thank you.
Sorry, I was eager.
You jumped
for
in.
my spot,
Sure.
my spot in the outline. Yeah, last
I
time
couldn't
I asked
see you
Daryl, and I
because-
was like, no, this is my time.
We've
This
been
is
gone
my
for 2
time
weeks,
where I
Chad.
play
This is
my
what happens when we
cards.
leave.
Seriously. I
Yeah,
couldn't.
next time I'm printing you a copy with my parts highlighted.
Wow. Well, that's what I do. So great for copying there.
Lauren does, actually. Yeah.
But when it comes to telehealth, what we're asking for, what we're asking Congress, CMS for everyone for, it's not a lot. We're not asking for more than what we already have. We're asking for stability.
Yeah.
We're asking for the ability to know the future if we're going to still have it. But we're urging Congress to make pandemic era telehealth flexibilities permanent. That includes payment parity, audio-only coverage, controlled substance prescribing via telehealth, federal licensing framework for cross-state care. And that's our main focus. That's our primary ask, and we're concerned about repeating the events of October when the government shut down and so many patients, millions of Americans and our seniors lost access to telehealth coverage.
Yeah, so what happens if we don't permanently expand telehealth flexibilities?
92% of AMGA medical groups say reduced reimbursement would decrease telehealth availability. So if we're not able to permanently expand telehealth, won't be able to cover it.
Yeah, we think about it. Our members have built the infrastructure. They made investments in this technology, which is, again, patient-facing. We talked about immediate resulting. So patients like this, they demand it, and the members need a stable platform going forward. Otherwise, why invest in this expensive technology, which is equally expensive of providing as a face-to-face visit? So all good. Well done. Daryl, what does CMS say about this?
Yeah, I think CMS has done as much as they can with this issue. So they've been, they've extended the flexibilities to the extent under current law. They provided payment parity. So I think, we had a series of really positive meetings with them a little while back, and they understood, to your point, that, providing care via telehealth or, in person really costs the same. It's the same process. So I think they understand that. To Lisa's point, though, like all that goes away if we don't fix this. And I think one of the other things that came out of the meetings this week, the CMI director Abe Sutton was talking about Access, this new model that they're rolling out of CMMI, and it's about telehealth and wearables and using technology to keep track of patients and all that. And we can have a whole podcast just on this Access model. But the issue with that, it's not directly related to telehealth, but it is in the sense that if groups and systems are going to make the effort to participate in this model, you have to have that underlying foundation of telehealth, right? And if that goes away, who's going to want to participate in this model that at its core is really based on this telehealth type technology? So that is a problem. And I think, if you don't get that foundation fixed first, it's going to be hard to see if a model like Access is going to be effective for, providers and patients.
And that is fair enough. Thanks. Okay, so telehealth is a big deal, but we're not just talking about telehealth in this letter. Is that correct?
Yeah, I think inflation-adjusted physician payment has been an issue ever since 2001. That's fallen more than 30% since 2001. And honestly, someone who worked on the Hill, and Lauren too, and Chad, with the calls on Christmas Eve about the doctors in your district saying, we need a patch. And that's not what doctors need to be doing. Probably providers, they need to be actually providing care, not worried about getting reimbursed. And when we talk about payment, we're not talking about their actual compensation. We're talking about how they're reimbursed for services they're providing and how they're taking care of their community. And doctors don't have control of costs of all the supplies involved in this physician payment fee schedule. And I think it's notable to mention that the fee schedule is the only schedule within CMS that doesn't have an inflationary adjustment.
Too true. So what's the result of all this?
The consequences extend far beyond provider income. Its inadequate payment undermines participation in these value-based care models, forces practices to limit Medicare patients, and it really hits rural and safety net hospitals the hardest.
That is true. Imagine not getting a raise since 2001. Okay, so what's our solution here?
Sure. So this goes back to some of our work with the Macro and Value-Based Task Force, which we've included in the package we sent over to HHS. But, for the sustainability or, Part B reimbursement, it's really, to Jamie's point, let's reform Part B so it includes an inflationary update, whether that's the Medicare Economic Index or another index to be named later. Great, as long as we've got that inflationary update. Also, you've got to reform the budget neutrality rules in Part B. Now, this gets tricky because, premiums are associated with Part B, so I appreciate that that's a problem. But what you can do is divorce the two. You can protect the premiums or move that out of the model or not have them directly linked to what the Part B spend is. So it's a total rework of Part B. But really, what we're talking about here is here's an older model that just doesn't make sense in 2026 and beyond, and how care is delivered and reimbursed. So what are we asking for? Let's figure out how to reform budget neutrality in Part B and tie it to some sort of inflationary update.
All right, I like it.
Yeah.
I think you used the word antiquated. I think our letter also touches on some antiquated statutes within Medicare. One of those things is the 3-day sniff rule, which is an acronym? No. Yeah, I think it's right.
Anachronism.
Thank you.
Yeah. I don't know what ASP to whatever is, but I know that word.
It's like oligarchy.
Yeah.
All right. So, Alicia, what is that, and what are we doing about it?
SNF, skilled nursing facility. So the rule you're talking about is a 1965 statute, which, for reference, is older than my parents.
That was the year I was born. Thank you. For the record, Lauren just said, "Eesh."
Well, my point is that how many things have changed since you were
That's
born,
so mean.
right?
Sorry,
She's lost it.
Man, okay.
Like I was saying, this is a disaster.
That's so deep. I'm sorry. It's just the way that you said it was so funny to me.
But, dang.
I'm shaking my head.
Yeah, thank you, Lisa. Please.
So this 1965 statute, it still requires that patients stay in the hospital for 3 inpatient days before Medicare will cover a skilled nursing facility care in one, regardless of what a physician recommends. CMS has waived it repeatedly through MSSP models, CMMI models, COVID waivers, and there's been no quality degradation experience. But only Congress can replace or eliminate it permanently.
That is true. Oh, okay, so you all were at this value meeting, Daryl, Jamie. What congressional folks were represented at these meetings, and what's the situation there?
Sure. I'll first start with the meeting that day. Darren and I went to a few meetings we'll talk about, but it was a wonderful day. They had glass bottles of Coca-Cola.
Oh, you had like 6 of them.
That is nice.
I was and they were small. So instead of having a big one, I had like 5 small ones.
We made the joke it was like Forrest Gump at the White House.
I was like, I like Dr. Pepper, like, but no, Representative Buchanan from Florida, who's the Health Subcommittee Chair and Ways and Means, Representative Schreier's office, she's a pediatrician and on the Energy and Commerce Committee from Washington State. those staffers are very in tune with what's happening. So they were talking about whether or not a reconciliation 2.0 is going to happen, and a lot of them were like, we're not sure there's enough time with the legislative calendar, with the midterm. So that didn't sound they weren't too clear about that. They focused on what the Ways and Means, Energy and Commerce Committee are talking about right now is affordability. And they're worried, obviously, about the midterms and how their constituents are concerned about affordability of healthcare and affordability of everything. There's a lot of talk about consolidation and addressing that, looking at the No Surprises Act. Buchanan is really interested in chronic care reform, and they talked about that a lot. And I should not have said I drank a Coca-Cola because Buchanan's really into Maha, and that was a mistake. Maybe so. The Coca-Cola was pure sugar; it wasn't fake sugar, right?
I had a water. Actually, that's not true. I had like 6 coffees, and they ran out of coffee. And oh my god,
Yeah.
it was like worst conference ever. Like during a break, we go like, oh, they didn't have. Yeah. Anyway.
Rookie mistake.
And
Andy Eberly would never have that happen.
No, of course.
Ever.
And come to AMGA's annual conference in Vegas. Plenty of coffee.
And lots.
There it is.
yeah.
Yeah.
Nice pitch.
Yeah,
And-
see?
Well done.
And Darryl, I would mention that the way they ended the Hill briefing, it was so weird because it's March, right? And they're like, "Yeah, we're thinking about a lame duck. What we're going to do in November." I'm like, "It's March, right?"
Oh yeah,
they're
they were definitely
already
talking about
what's
it's like
after the midterms.
after the midterms. Like season's over.
Yeah.
Come back. You know. It's like, oh, okay.
But very knowledgeable staff, especially if you're listening. You're very knowledgeable.
It's like the Capitals playoff hopes. All right. So, Jamie, you mentioned chronic care. Let's talk about the future of coordinated care, APMs, MA, and accountability. What's our positioning on advanced APMs?
Sure. So in our letter, we've got a whole section about what APMs are all about from the perspective of our members. And really, this is not news to anybody listening to this. It's designed about organizational accountability, shared risk, shared savings, shared investment, and care management structures. And there have been some changes over at CMS in how they are structuring some of their models and programming that sort of, in our opinion, sort of moves away from that. Things like using individual level QP determinations or mandatory specialty payment models like this new ambulatory specialty model. I think that you start to fragment what the whole point of an accountable care organization or an APM is. If you win or lose as a team, and CMS is going to allow individuals to qualify as an APM, that sort of undermines the entire concept, I think. I know why they're doing it. They want to show a number of clinicians are in some sort of value-based or high-value-based model. So this is a way to bump up your numbers a little bit. But that's not the direction that we think they should go.
Agreed. And honestly, it feels like we fought this 15 years ago, which is why the group practice reporting option was created. So
Yeah.
you could actually report at the group practice level. And it sounds like we'll fight this thing again.
And then, you build on that and you've got something like this ASM model. It's like, this is just a repackaged version of MIPS. And the whole point of being in an APM was to avoid or not have to be subject to the MIPS reporting requirements and that sort of thing. But they've sort of repackaged MIPS and now made it mandatory for a select group.
All right. Something for us to work on.
Yeah.
Okay, finally, MA. How does it fit into all this?
So Jamie and I were at the BMA, Better Medicare Alliance Summit. Jerry sort of kicked it off with a video message to them, so I was kind of neat to. I recognized that voice. I look up like, oh, it's Jerry. That's fantastic. What was really interesting about this is they had CMS's Chris Clombin. He just got promoted or dragooned into the secretary's office as well. So he's wearing multiple hats. And he was talking about how Medicare Advantage cannot simply be like a margin tack onto the fee-for-service system. And they are definitely focused on changing the risk adjustment structure so you are competing on the actual benefits and services that can be financed through MA and not, in their view, winning based on risk adjustment. So they are taking a serious look at MA and they want it to compete with a value-based model in the fee-for-service realm as well. So I think MA has a lot of promise. It's more than half the beneficiaries at this point. So getting MA right is going to be a challenge over the next several years.
Yep, and I'm not speaking out of turn here because this was filmed and it's online, but these CMS officials were they were aggressive and what they wanted to accomplish, and I think they said something that was very interesting for our members to understand. They want to hear your thoughts, and they do care, but they care. There are two main things they care about more than anything else: is the beneficiary and the taxpayer. Those are the things they care about most. Now, that's something we all need to think about when we're making our arguments to these CMS officials. And they also just said, we want to make sure these MA models are providing the best level of care. They also mentioned a little bit about AI, and I was fascinated to hear their perspectives on this because they were like, this is another technology that we want to make sure we don't flub and we use it. I think Chris was talking about the internet and EHRs and all these things. And it's like they didn't really revolutionize healthcare because there's still problems with it.
Yeah.
And
yeah.
I was shocked. I mean, he sorry.
No. Well, I think what to sort of paraphrase what he said is like healthcare will take a technology and cram it into the ground or pound it in the ground so it breaks. This is why we still use fax machines.
Yeah. And Chris, he also mentioned like for AI, they're like, we want interoperability of data. And I'm like, yes. And then he's like, reg framework is arcane needs to be fixed, which is part of Daryl's communications with HHS and CMS already. But another thing he said, which makes sense about solvency, was MA needs to be a deflationary payment mechanism. It needs to get rid of the administrative burden, but it also needs to basically be able to buy more things with less money.
Yeah.
And I think our members, that's how CMS is thinking right now. So we all really need to be aware, and that CMS, all they want to make sure is the patient has the choice, and competition is key in the market.
Right. And you're competing based on how you are offering benefits and being good stewards of taxpayer dollars.
All right. Well, one of the ways to reduce costs is to reduce regulations. And I think this letter that we sent to the Secretary's office, which is currently at his desk, is a great way for them to start doing that exact thing. Thank you all for an outstanding policy podcast. Thank you, Miss Latney, for a great cake. And we want to say, hope you all have a good day and see you all soon at Annual Conference Las Vegas this April. All right. Have a good day.
Thanks for joining us for Filibusters in Fine Print. This podcast was brought to you by AMGA. For more information about AMGA's advocacy efforts, visit amga.org/advocacy.